moderating, right?
Yeah,
No,
so in
Dr.
fact, we are waiting for go ahead from Dr. Halima.
Yes. Razia, please say you welcome. Okay. Bismillahirrahmanirrahim. Dear all SOGP members, viewers, healthcare providers, we are going to start our second day of the virtual SOGP Symposium's proceedings with the name of Allah, with the recitation of the Holy Quran. Bismillahirrahmanirrahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahu al-Azim. So I am, on behalf of SOGP, I am very thankful to IPAS, especially Dr. Shabir, for organizing this virtual symposium on the post-abortion care, very hot topic. So we are going to start this, and all the panelists. I am thankful to all the speakers, especially Professor Farooq Sama. When he was the president, I was the general secretary. So I remember we old days. So Dr. Farooq, thank you so much for your kind support to be here in all supporting to SOGP. So we hope all of you. So डॉक्टर शबीर के साथ भी मेरा बड़ा पुराना ताल्लुक है. जब हम लोग पीगो का प्रोजेक्ट कर रहे थे तो ये भी हमारे साथ बहुत इन्वॉल्व थे. तो डॉक्टर यास्मीन काजी तो खैर बहुत ही वेल नोन पर्सनैलिटी हैं ये.
We lost Dr. Razia, I believe.
Yeah.
Dr. Razia, your mic is on mute.
Dr. Yasmin Kazi, she is the moderator of today's session. So Dr. Yasmin Kazi is a medical director with a vast experience in public health field. She is a well-known reproductive health expert in the country and has remained an active advocate for women's health issues through her association more than 25 years. She is associated with donors and NGOs on reproductive health matters in country and internationally, and recipient of various awards for her achievement. She is a board member of PPIF, Punjab Population Innovation Fund, established by Government of Punjab. She has recently been honored to be listed in top 100 women leaders in global health in Pakistan. So thank you very much, Dr. Yasmin. Now I am handing over the mic to you. Please you carry on your session.
Thank you so much, Dr. Razia, for this very elaborate introduction. Assalamu alaikum, everyone. Good afternoon to all respected delegates of this symposium, but also the one who's watching virtually and going to listen to an issue that's usually brushed under the carpet, and that is not something that is, looking at a decade and a half ago, this was not the kind of a subject that would be part of public seminars or would be framed in a way, but we have traveled a long distance, and I see many of those who have walked with us in this journey and made it possible. So very quickly, the today's topic is addressing and realizing women's need for comprehensive abortion care, the best practices and innovative approaches in Pakistan context. I'll just say a few words about the issue itself, but I know that I would leave the rest on the experts who will be speaking. But just, the unsafe abortion and the morbidities and mortalities attached to the unsafe abortion was not really a recognized need in the public health spectrum way back in early 2000 when we started to work on that and produced an evidence about the scale of the issue in the country. So the Population Council research, which they have now done twice, and actually we are due for another incidence survey, In 2002 and 3, they have shown nearly 1 million women would undergo induced abortion in country. And when it was repeated, the incidence was repeated in 2012 and 13, the number has risen to more than 2 million, 2.2 million. And we know that it might be still not the right number. What does it signify? I think this single number, because every number has a story, and that story needs to be understood. But for some, it might be just an indicator or just a number. But for all of us, I mean, many of us who are here today as an advocate for women's health issues and her right to access quality healthcare issues, we know this number has a lot of stories to tell about a women empowerment, about her decision making cycle, about her ability to access contraceptive in time, and about her ability to decide about her fertility pathway. And we know that this is not happening. It's an unmet need for family planning and birth spacing. Every induced abortion indicates that it's missed time, it's unwanted, and there are several reasons for it. Non-use of contraceptive, less compliance of contraceptives, and even with the best compliance of contraceptive, every contraceptive has a failure rate. So we cannot, this kind of a blame game that we start, why women are getting pregnant with untimed pregnancy. It is the women who has to be blamed. It's not something that can be a. It is a very sweeping statement, and we need to understand in what circumstances women are coming up and going for these induced abortions. And if she is not able to get the quality of services, and we know there are several factors which I'm sure the speakers would be talking about. I was just thinking about it, the entire stigma, which is global. The entire US election is sometime won and lost on this single issue. We know about the providers' biases, not only for comprehensive abortion care, post abortion care, but also for family planning and contraception. And there is not only provider biases, there are system biases as well. But Pakistan is kind of a case study. Shabir is here, IPAS is here, Sadia is here, and all those champions, Rubina and SOGP members. That how this trajectory has been traveled and what we have been able to achieve, and we'll be looking forward for that. So if I can ask the organizers to please flash the program for today, I'll just quickly say what we will be doing. So we will be, after, we are very honored to have Dr. Atia Abru as a chair for this panel, and she's the Deputy Director at the National Ministry of Health and Regulation. And then I'll be inviting our keynote speaker for the day, Professor Farooq Zaman, and I'll be just introducing him in a while. And after that, the second speaker of the day will be Dr. Shabir, who's the Country Director of IPAS. And after that, we have a very star-studded panel. And in that panel, we have a combination of a legal expert. We have a combination of our champions, the gynecologist champion like Dr. Noreen and, Professor Sadia, Dr. Noreen Zafar. And then we have, Sayed Safir Hussain Shah, who's going to be our legal advocate, would talk about the legal aspects. And we have, the Midwifery Association President Arusa Lakhani, because task shifting and task sharing is very important in this entire trajectory. And then we have a young leader which comes from an innovation of telehealth. Dr. Sarah Said will be talking about how this could be done through innovation and through technology, which has become so critical and so important in the recent, COVID era and in the pandemic. And then I'll be requesting and inviting Dr. Atia to do the closing as a chair we'll try to collect what are the things that needs further work from all of us. How could we do it collectively? How this community can work towards improving women access to safe abortion and post-abortion care, and how, if there are few action items, then we can take forward. So this is the structure for today. And with that, I would like to invite our first speaker, who is, who is such a worthy man. And, I don't have enough words to introduce him, Professor Farooq Zaman, who has multiple degrees, and of course has been a professor and has retired from the public sector, but he has been working very actively in the field of um, gynecology. But most importantly, he's among those champions, the male champions that we have already always looked at when we had started working on that. So Professor Farooq Zaman has a lot to tell as a story, but also how men as providers and how men as partners, I think, can make this journey easy. So I was reading the short bio, and I was very impressed to see he was one of the pioneer in the IVF technology, and of course he's still working very actively as dean and professor of obs and gynae in Rashid Latif Medical College. So with that, over to you, Dr. Farooq Zaman, and you have 15 minutes for your presentation. Thank you. Dr. Farooq, please unmute yourself.
Thank you very much, Dr. Kazi, for the introduction of the subject particularly. I'd like to congratulate right in the beginning Professor Razia Kurejo, Professor Halima, and all the executive of SOGP for organizing this wonderful conference on a virtual basis because of the current COVID situation. I'd also like to thank and congratulate IPAS, particularly Dr. Shabir, for the good work that IPAS is doing in introducing this very delicate subject of abortions in Pakistani context. They need to be applauded for IPAS and all the team members of Dr. Shabir because, as they continue to inform and educate health professionals and all who are concerned with this subject about the importance of the abortions in women's reproductive, sexual, and general health. And also, I must thank IPAS for inviting me at this seminar. Right. Well, we know the definition of the abortion, and we also know what an unsafe abortion is. I recently came across this paper in Lancet, which was published only 3 months back, and it has shed light on unintended pregnancy and abortion and its various components on a global level. And it has compared the situation that was about 25 years ago or 30 years ago and what it has been now. And the figures are, as Dr. Kazi was mentioning about the situation in Pakistan, about the Pop Council study, you see, the situation all over the world globally has not improved so far as abortion facilities and abortion services are concerned. Of all the pregnancies, unintended pregnancies, which end in abortion, that's a large, huge number, 61% of them. And the global abortion rate is to the tune of 39 women per 1,000 women of reproductive age. And if we look at it, the number is 3 out of 10 of all pregnancies and 6 out of 10 of all unintended pregnancies. That's a huge number. But this one particular slide, I would want you to pay some attention to it because this is quite revealing. You see, in 1994, the rate per 1,000 women of unintended pregnancies was 79. And in the 5 years time period of 2015 and 19, it has come down to 64, about 1.5% decrease. But surprisingly, the abortion rate has not been affected at all during these almost 30 years, 3 decades. From 40, it still is at 39. So it has not really been affected at all, which is rather surprising. One would have thought that with so much of advocacy about contraception and all that, the rate would be much less, and at a global level particularly. And then this was another surprise. When you look at the figures coming from UK, that this is the Royal College's estimation that prevalence of induced abortion is such that 30 to 35 to 40% women, by the time they reach the age of 45, they have experienced an abortion. And this is in a country where abortion is not very hard to come by or to obtain. And this is one of the most commonly performed gynecological procedure in fit young women. I think these are a couple of information pieces which all healthcare professionals, particularly the senior OBGY professionals, need to take notice of. When we look at the Pop Council study, which was referred to earlier, the abortion rate in Pakistan is rather high. It's 50 per 1,000 women. And there is variation, some variation in different provinces of the country, but the rate is 50 per 1,000, which is quite high. And this is a very nice article that came up in Dawn, written by Ms. Zofine T. Ibrahim. And this particular graphic, I thought, was depicting the gruesome reality and situation that we have in our country vis-a-vis abortions. That the rate is 50 per 1,000, and this was calculated in 2014 by Pop Council study. And 48% of the pregnancies are unintended pregnancies. So only 52% pregnancies are required, and that is because of lack of use of contraception. And 6,000 plus abortions per day. That's a huge number. And this is the comparison that Dr. Kazi was referring to, that in 2002, there were 2.4 million unintended pregnancies compared to 4 million intended pregnancies. But that ratio had been disturbed greatly by within 10 years. There were 4.51 million unintended pregnancies compared to 4.8. So the ratio was becoming bigger and bigger, and that is despite various departments and government at government level endeavors to provide contraception and to talk about family planning. Probably we have not been doing our work as much as we should have done. Now, if we look at the abortions of 73.3 million abortions that take place every year globally, out of them 55% are considered to be safe, and 31% are considered to be less safe. But this is the 14% which is the least safe abortions. Now, this is a global assessment. How many of abortions taking place in Pakistan are least safe? That is something that we can only guess about, and we don't really have exact figures for that. Now, this is again a paper which came out in 2015 in British Journal of Obstetrics and Gynecology, in which figures were collected from 26 countries about the complications which are met with in cases of abortions. And within this region, less developed region, there were 7 million cases, women who were treated for complications for pregnancy. Amongst these, actually, 60% were dealt with in health facilities, but 40%, that's a huge number, which is about 2.8 million of these women did not get adequate care. And we all know that abortions contribute greatly to the burden of morbidity and mortality of women in the developing world. We know that up to 13% of maternal mortalities are caused by the complications as a result of abortions. Again, going back to that Pop Council study, the estimated number of women who had abortions in 2012 was 2.25 million. And amongst these, more than 600,000, they had complications and they were treated in various facilities. If we look at this figure, which was published in, and it has been taken from Pop Council study, if you look at some of the regional countries, Pakistan fares rather poorly amongst them. You see, the annual treatment rate in pregnancy termination complications is the highest here in Pakistan at 14.6, whereas in all other countries which are given here, it has not gone beyond a single digit. So that just shows the extent of the problem that we are faced with. If you look at the, now we generally tend to think that it is the lack of contraception practice that probably so many women resort to abortions. That is a very important contributing factor. And if we look at the performance of our efforts towards family planning, honestly speaking, we can't really be proud of those. In more than 25 years, we were just able to bring a fertility rate from 4.9 to 3.6, which again remains the highest in the region and amongst the highest in the world as well. And then the contraceptive prevalence rate. I was quite disturbed looking at this graph. You'll see the practice is 25% any modern method. But if you look at the detail, you see 8.8% is female sterilization and 9.2 is condom, which amongst the modern methods is most prone to failure. Injectables 2.5, IUDs 2.1, pills 1.2, long-acting 0.2, and if you look at the implants, again 0.4. So about 18% of this 25 is 18 out of these 25 actually are female sterilization and condoms. So which again is a point that we should be reflecting upon. And this is again quite disturbing. Coming from the Demographic and Health Survey, if you look at the trends in various methods, traditional method, any method, or the modern methods, this graph has plateaued. It is not rising up, and it has become stationary for the last almost a decade. And I don't have any reason to see that it would have gone anywhere above that. So whereas it was up to 30 in 2006-7, it rose up to 35 in about 5 years' time, but after that, it just plateaued. So this is the status of family planning practices in Pakistan. But I want to make another point as well, that it is not only lack of contraception which is responsible for women seeking abortions. If you look here at the conceptions and the percentage that led to abortions in England and Wales in 2017, about more than 20%, 20 women out of 1,000, they sought abortion. And that obviously was more common in younger women, but that's a considerable number considering the literacy, the easy accessibility, availability of contraception and the practice. So therefore, there is more to it than just lack of contraception, which is responsible for a higher rate of abortions. And the grounds, the most common ground was physical and mental health, which again is a ruse for, just seeking abortions, because that's a convenient term that can be utilized And we too, sometimes whenever we are inclined to perform the procedure, we would say that there is danger to physical and mental well-being of the woman. These are the abortion laws. Pakistan is not so restrictive. As a matter of fact, I think that we should take Pakistan's law as a rather liberal kind of thing. Here, there are two indications. One is to save the life of the mother, and also to preserve health. So we have two indications for which. Now, how does the law affect the number of abortions or morbidity and mortality related to this? Here, if you look at the figures from England and Wales, in 1952, the rate was quite high for therapeutic, spontaneous, and illegal abortions. There were considerable number of illegal abortions, and the deaths accruing from or because of those. In 1967, the law became liberal in UK, which resulted in availability of therapeutic abortion or abortion with skilled hands. And just look at the mortality, which has come down since then from 67 onwards. And in 2003-5 triennium, the mortality was very small, nil for illegal or spontaneous abortions. And so therefore, the law has had a lot of considerable impact on the number of deaths, and not only law, but availability also of the facilities and the skill for this. And the current law in Pakistan permits abortion to save the life, a woman's life, as well as in early pregnancy to provide necessary treatment. And abortion is legal to save the woman's life or provide necessary treatment. And there is consensus among major Islamic schools of thought regarding the concept of ensoulment at 120 days. But the important fact is that more than 95% of practicing doctors and health workers, they are unaware of the abortion law or Islamic concepts about abortion. This was the assessment in the workshops carried out by various professionals. Now, the interesting fact which came out of that Lancet study was that in countries where abortion was restricted, the proportion of unintended pregnancies ending in abortion had increased compared with the proportion that of 1994. And also, unintended pregnancies were higher in countries where abortion was broadly legal compared to those in these countries where there is restriction on abortions. And the restrictions, we all are aware of that. Restrictive laws, we don't really have a restrictive law. Poor availability of services, yes, we have. High cost, I don't really think that's much of a problem because we do not have many facilities. Stigma, yes, a very significant factor. But there is also this conscientious objection of healthcare providers. Amongst the panel and other professionals who are sitting here, myself included, we are quite liberal so far as discussions are concerned, so far as presentations are concerned. But when we are faced with someone who seeks abortion, then we start having cold feet. We are not as forthcoming with the provision of these services as one would want. So that is also a point for our reflection. Globally, unintended pregnancies declined during the period from 90 to 2015 and 19. But unintended pregnancies ending in abortion, that percentage increased. And because of that, the global average abortion rate, that has remained the same as it was in 1994. This is an important, again, slide to look at. If you see maternal mortality in pregnancies, that is 4.8 per thousand in England and Wales. And if you look at the mortality because of the skilled abortions, it is 0.15 per 100,000. And risk of death associated with abortion is 32 times lower than with childbirth. Now, this is the case if there is that facility available. The point that I am trying to make is that contraception use is not the only factor which comes in way of abortion care. That is one, because even in those countries where contraception is widely practiced, is easily available, and people are knowledgeable enough to use that, even there is a significant incidence and prevalence of abortions. But if safe abortion facilities are available, then the morbidity and mortality is much less than in the full-term pregnancies. In conclusion, I would say that women continue to seek abortions, whether access is readily available or it is restrictive. And unsafe abortion remains a major cause of mortality and long-term morbidity. And therefore, it is important for all of us to ensure that sexual and reproductive health services access be made available to all women. And we must propagate family planning and use of contraception. And above all, if we want to reduce maternal morbidity and mortality associated with abortions, we need to develop services which will provide that. That's a long and tall order to ask for. But I think that since IPAS has started making or taking this initiative and started also taking innovative approaches, and they are working very hard. Apparently, it may seem that the progress so far made is not that great, but I think if we continue to strive for getting results, we keep informing our professional colleagues and continue to invest in this area, I think that we will reach somewhere. Lastly, the last slide that I want to show is again a matter of great reflection, and that I borrowed from the Bangladesh presentation yesterday. You just look at the CPR in Pakistan, 25 per 1,000 women, or whatever figure is here, and their figure is 54.1. And that again is pill 29, injectable 12.4, condom 6.4, female sterilization. You just compare these figures and that'll give us a lot of food for thought. Thank you very much.
Thank you, Dr. Thank you, Dr. Farooq. I think you have set a great, kind of a context to invite me the next speaker. And this is great, information, not new, but every time it is repeated, it's kind of, it hits you. So the next speaker is going to be Dr. Shabir. Dr. Shabir Awan, who is the country director for APAS. He started working in APAS as technical advisor in 2012, and then became the country director in 2013. He has a lot of stories to tell, so I leave up to him what he prioritized. He's a public health specialist, and previously he also worked with UNFPA. Dr. Shabir, if I can request you to limit your presentation to 12 minutes, because Dr. Farooq, I didn't want to stop Dr. Farooq. It has really, a little overshot in few minutes. You can manage that so we can allow panels to discuss. Over to you, Dr. Shabir.
Sure, I will. Thank you. So thank you very much, Dr. Yasmin, and thank you, Dr. Farooq. I think, yes, you have actually set that ground on which I can build with my presentation. So next slide. So basically, I will not go in details. Actually, Dr. Farooq has already mentioned where we lie in the data and all the consequences due to unsafe abortion. But important thing is that this is one of the contributory factor towards high maternal deaths in Pakistan. And it is probably underreported that we say it is 6%. It is 13% women die due to unsafe abortion in developing countries, and Pakistan is one of them. So I would just mention the last bullet under the Pakistan context. Like more than 90% of what IPAS has collected the data from almost 300 facilities during last few years. of post-abortion care that 70,000 women have reported to public, mainly the public health facilities and some of the private sector facilities out of these 300. So if we see the data, more than 90% women are coming to these facilities with incomplete abortion or missed abortion, and mostly these are incomplete abortion. So it means that at the community level, they are actually uh, self-managing, or they are being managed by the untrained providers, or even quacks are in the back street. So therefore, they are not being able to get the process safely completed, and they have to come to the facilities. So this is one of the important point to consider when we say that we have to improve the safe abortion care in the continuum of the health service package, starting from the individual level, in the community, household, in the community, and coming to the health system. So that may be very important for consideration in Pakistan. Next, please. Yeah, so again, important thing is that this restrictive, or you can say the limited access to safe abortion care, mainly it is due to high stigma, the myths, misconceptions, and the providers' biases. And another important thing is that there is a lack of knowledge about early fertility return. Therefore, the stigma from the abortion is spilling to basically family planning also. That becomes so important, that to break the vicious cycle of unintended pregnancies. So it's important that counseling and family planning services are being provided. So that is due to lack of knowledge about early fertility return, that within 8 to 15 days of after an abortion, next pregnancy can happen. So if we follow and improve the accessibility and use of contraceptive services, so basically 25 to 35% maternal deaths can be averted. So that is one of the significant point to consider. So what IPES is doing, next please. IPES is working with the public sector, with the stakeholders, with the partners, some of the components also related with the private sector. So we are actually trying to build to all those efforts where we can improve accessibility to high quality, safe abortion and post-abortion care and contraception. Next slide. So as Dr. Farooq has mentioned, in fact, this is quite a challenging processes and the pathways we have followed. But I would say that in 2009-10, we have a strong pledge from the government in the shape of Karachi Declaration, where post-abortion care was taken up as one of the safe best practices on MNCH. And I would like to give credit to Dr. Yasmin Kazi and many of the champions in reproductive health. Dr. Sadia is with us, Dr. Rubina Suhail is with us, and many other champions, and our champions in the government sector also, that we have been able to break that fabric within the policy level systems, that after that pledge, we have actually softened some of the environment in terms of policy enabling environment towards moving towards piloting some of the training from the tertiary level, where we can actually address the mindsets of switching from DNC to safe techniques of misoprostol and MVA. And then now we are actually scaling up to the primary healthcare level. During last few years, the government has championed to introduce the safe abortion standards and guidelines, starting from Punjab and to the national level, and now Sindh has adopted those guidelines. So I think it's a need for other provinces also to adopt these guidelines. There has been procurement or sustainability of commodity issues, but because when you go for trainings, it's important that commodities are ensured. So Punjab has taken lead in that context, that they have procured a huge quantity of misoprostol, like 10 million misoprostol in last few years, and also 5,000 MVAs, where they have actually distributed it to the health facilities. But now important thing is that if the commodities are available, it's important that all the providers at those facilities should be adequately trained, that they offer the services 24/7. So you can see this trajectory as we can see in Pakistan context, that the high restrictive or limitations in access to safe abortion care, now we have reached to, you can say, a phase where the policy environment is like quite helping or enabling in terms of giving the standards and guidelines. As Dr. Farooq has mentioned, the standard and guideline includes the addressing the consensus objection for the service provider, that providers they can actually refuse providing the services if they want, but they have to ensure that they refer the women to safe providers around them. And if there is no possibility of safe abortion care in their surrounding, they have to actually provide safe abortion care. But this is actually this is to be implemented and very important in terms of Pakistan context. Next, please. So quickly, we have started from where many of the like-minded organizations, I mentioned that the champions have played role. We have been able to create a national level consortium, Pakistan Alliance for Post-Abortion Care, almost now a decade ago. And our collaborations have expanded from the national level to the provincial levels. These standards and guidelines have also been scaled up from national level to the provincial level. Next, please. These are some of the clinical trainings IPAS have been doing. The values clarification, I would like to give credit to Dr. Sadia Hassan, who basically, Sadia Paul, who actually, she is one of the champion who has led these values clarification activities. This is very important when providers have myths, misconceptions, and they are one of the big barrier, particularly from when we talk about the context in the service provision, and quite judgmental and many of the examples we see. So I think this is important that values clarification and clinical trainings are merged as one package so champion providers can come up. So IPAS is doing efforts to include safe abortion care clinical trainings in the health system and essential health service package. Next, please. We have been able to introduce social behavior change, that is IEC material for lady health workers and the male part of the community, basically men, where we have introduced the IEC materials. We have piloted in few districts, and now we have been able to scale up to a significant number where these lady health workers and the male outreach staff, they work with their communities to educate them on the safe pathways, and particularly the delays which we come across. Next. So I will share some of the data, actually, what we have been able to collect from these 300 facilities. If you see that we have trained around more than 700 providers. So it's a big number. We have been able to collaborate with the government in these 300 facilities and some of the private sector facilities, that around 80,000 women have been treated with safe technologies. So I think that is important thing, that switching from DNC, which is an obsolete method, to the safe technologies, and then counseling and providing this post-abortion family planning, it's almost 60% that these women are taking up at those facilities. And they are bridging the family planning uptake from the short-term methods. Currently it's high, but we have seen a good increase in long-term methods, and that is actually needs to be built up. Next. The important factor which we have seen, that training the community intermediaries, particularly the lady health worker, that they have started referring, educating the women and referring these women from the rural communities where they work to the safe providers. So that is one of the important factor we have seen due to these IEC interventions. Next. So this is like during COVID, where in-person attendance of the women has continued to the health facilities, but certainly it was one of the barrier we have seen, and I will discuss shortly that we have compared last 9 to 10 months in last year and the same 9 to 10 months during COVID. You can see that the UE and PAC, uterine evacuation and post-abortion care services coming to these 88 health facilities where we are working now, that the number is almost the same, but post-abortion family planning has gone up. And there's also an increase in uptake of long-acting reversible contraceptive. So that was probably to control their exposure to COVID. when they were adopting the long-acting reversible contraceptives. Next, please. So IPAS has been able to support the government systems with the providers protection equipment and some of the supplies. Next. We have worked with the government, as all other champions have contributed, that the safe abortion should be made a part of essential health services. And we have also been working with the health managers and facility managers to include misoprostol and family planning commodities in their procurements during this COVID. Next, please. So few things which we have done differently during the COVID. We have piloted telehealth initiative. I will discuss some details. We have been able to continue capacity building of additional providers and refresher for the previously trained providers. We have continued with e-mentoring and on-job troubleshooting through e-modes. And also we have been able to connect with the lady health workers and the pharmacist to ensure that misoprostol should be available at the pharmacies also. Next. So telehealth initiative is one of the important intervention we have taken up. That was in collaboration with Sehat Kahani. Thank you, Dr. Sara, which is one of the panelists. But with the public sector and Sehat Kahani, we have signed an MOU and piloted this intervention across the districts where we are working to get the referrals from the women for teleconsultations. So lady health workers have been tapped as the referral sort of accompaniment model to educate the women and link them with these telehealth providers. Next. So we are experiencing some good results from these linkages, that lady health workers are able to connect women from the rural areas with these trained telehealth providers and to get counseling and advice on medical abortion and post-abortion family planning. Next. These are the trainings we have conducted during the COVID. These were the online trainings, including online values clarification workshops for the providers, for these telehealth providers. And we have actually supported them to enable to provide the advice to their women, to the women who come in contact. Next. So these are some of the results. So I think this is the intervention which would be the landmark by gradual building up on our experiences, learning by doing, and coming across many of the challenges, and then improving our approach. So during last few months, we have seen that 135 women have contacted the telehealth mode. And
can I request you to conclude quickly,
yeah,
please?
Sure. So 64 women were able to get the teleconsultations, and you can see 31 consultations on abortion-related matters and 10 family planning consultation. So this is a slow building data, but certainly this is one of the platform that women are now accessing to contact the telehealth providers and to get advice on the safe abortion care and post-abortion care. Next. Next slide, please. Yeah, so I think this intervention has built the community's confidence on lady health workers, that they have been able to connect the women from rural community with the safe telehealth providers. And some of the women from the community have shared their experiences. They are very excited to be in contact with these safe providers. Next, please. Yeah, as I mentioned, that we have been able to connect with the service providers and the lady health workers. So that was one of the important step, that to engage parallelly with the demand side, so that the service utilization should go as we have planned to connect the women with the trained service providers and commodities. Next, please. We have been able to continue the trainings on family planning and post-abortion family planning and medical abortion. So we have followed the virtual mode, like you can see trainings on McWheel. Next. In one of the training, the Vice Chancellor of Nishtar Hospital University joined the training, and he was actually very much impressed the way the trainers were involved in training, trickle-down training to these providers and PG students in their hospitals. And I think that is one of the things that we have continued during COVID. Next. some of the messages which were developed and for the lady health workers and pharmacists in the local language. Next. This is the last slide. So what are our learnings to work during the emergencies and crisis situation? We have been able to adapt to changing environment, IT technology skills. This is the need of the time. Like basically, the important thing is to develop partnerships and effective partnerships. So use of data and frequent reviews, that is also one of the process we have learned. And then ownership at all levels, that could only come with the frequent consistent follow-up, and certainly documentation and dissemination of the best practices, and to build up the institutional memories for the upcoming days. Thank you. This is all from my presentation.
Thank you, Dr. Shabir. And we'll hold the questions thing because we need to now quickly move to our worthy panelist. And what I will do, I'll invite one of the panelists introduce that particular speaker and then ask a question which they can respond. I'll again request the speakers to keep the timeline of not more than 5 minutes. We have not been able to manage the first part so well, so I'll try to do that in the second part. So I would like to begin with the asking the legal expert. So Mr. Safir Hussain, who is a High Court and a Federal Sharia Court advocate. He's been engaged in this work from a long time, and I'm reading that he's working with NGO Sahil, working on the child sexual abuse and processing all the cases on behalf of them. And my question to you, Safir Saab, is really that you have heard about you must have heard about the abortion law in Pakistan, and you're hearing from the key speakers in the morning as well. The question is that how this law can be interpreted for our providers, because we see most of the providers having the biases and barriers. Professor was telling us that it is one of the actually a more liberal law compared to the restrictive law. How can we make the narrative to make it easier for our providers? But from your own perspective, how do you find this law from that angle? Over to you, Safisa.
Thank you very much, Dr. Yasmin Kazi, and I'm very appreciated the IPAS and also Dr. Shabir that inviting me again to speak on the abortion law. I really thinking that in Pakistan, only one thing I have listened from Dr. Farooq Zaman and also from the Dr. Shabir, that the awareness of the law in Pakistan is very important. Because last year when I attended in Lahore of conference, that I observed that many gynecologist doctors from throughout the Pakistan asked me question about the abortion law. So I think that it's need to be more aware to the gynecologist and also the staff of the medical staff and also the other doctors, at least on the abortion law. I try my level best to conclude within time, but only I can refer one section and then I try to detail on this section. This is a Pakistan Penal Code, the section 338 that I'm just read it in 3 lines. Skate Hamal, whoever caused a woman with child whom organs have not been formed to miscarriage, if such miscarriage is not caused in good faith for the purpose of the saving the life of the woman or providing necessary treatment to her. I have seen one slide from Dr. Farooq Zaman that very shortly they have given 2 points. One is that to saving the life of a woman. The other is the necessary treatment. This is a very wide subject, very wide, and a lot of question for the doctors and the paramedical staff in this regard. This is the main section as main law as provided in Pakistan Penal Code 338 section. So I feel that 4 important things. I'm not going in detail the judgment, but last time when I updated in 2019, at that time there was no conviction, or there was no any even reported nominated by the medical staff in such cases. So I have updated right now up to today that there was all the same result, that there's no one nominated from the uh, medical core or medical things. Four things are very important. Number one is that the lady must be above 18 years, is very important in Pakistan. Number second is the willingness of the lady for abortion. Number third is that if anybody, and who will be the complainant, and miscarriage is also very important, play a very important role. I have seen the all presentation that many cases naturally they come to the doctors for miscarriage cases, or like this. We cannot say the formal abortion, but we can say that miscarriage due to some certain reason. So who will determine that this marriage miscarriage is the naturally happened in this incident, or there was planned on there were formal abortion? This is the very also the big cushion uh, in hand of the doctors. The other thing is that who will be the complainant? For example, if the above 18 years lady and also she is willing in this regard, so who will be the complainant? If legally, if they, or for example, if she's married and then she's coming for abortion without consent of her husband, so it is another question. And if in other words, in otherwise, so it will be the different. One thing is very important, that in Pakistan, although it's not a particular number, but a lot of abortion cases, a lot of abortion are doing in Pakistan. So how many complaints are registered in Pakistan? For example, according to this law, although anyone can launch a complaint if, for example, if the 18 years are not willing, so on this basis, anyone can launch a complaint. But there is, I think, no one complain in this regard. So it means that it is very safe in Pakistan, and the provision of law is also have a lot of cushion in Pakistan regarding this. And the one thing which is very important, they can determine by the doctors that is in this particular section, one thing which was very important, whose organ have not been formed or developed. So it means that at what time the organs of the child can be developed. This is the medical subject, not my subject, but even then, this is very important in the eye of law, that whether is a 120 days or whether is a 13 weeks, and it's up to the doctors. One thing that also another thing that doctors cannot aware, doctors are not aware that doctors have a lot of powers. No one can change the opinion of a doctor in these questions, whether we can say the necessary treatment or the save the life of the woman, and if she's above 18 years and no one complaining. But the thing is that the doctor's opinion cannot be challenged even in the competent court of law. Only and only if any complaint received on any application received, even during the pendency of the case, during the proceeding of the case. But even then, the judges, even I can say the High Courts and Supreme Court, can only ask an order to develop to for the medical board or the senior doctors or more than one doctors. They can determine the whether the doctors had doing in these things is not only in the abortion cases, this is all criminal cases, and doctors play a very important role. And I think we need to aware the doctors and paramedical staff on these issues, and the particularly on the laws. And laws are very much clear, and I can explain the other also the 338 A, B, C, but we have very short time. So I can also provide you a lot of judgments on in this regard. So thank you very much for your inviting me.
Thank you so much, Safi Saab, and thanks a lot for not only telling us what are the things that can be looked at from a positive angle, and what are the things, I mean, I think the most critical decision for us as a community is to really, should we start talking about making this law more legal and more open, and just ruffling the feathers, or just looking at the points where. So thank you so much, and thanks for also sticking to the time. Dr. Atia Abru is our chair of the panel, but I would, since she's the public health expert who is here, so I would really like to pose my second question to her as a panelist as well, because we would like to hear from her perspective. So Dr. Atia has been a part of a public sector from a longish time. She has served in the department, Population Welfare Department of Punjab for 15 years, and then now she's serving as the focal point for RMNCAH, and she's the Deputy Director Program in the Federal Ministry of Health and Regulation. And she looks after reproductive, maternal, newborn, child, and adolescent health. And she is our to-go person in the Federal Ministry. So my question to you, Dr. Atia, that we have seen recently some very transformative steps being taken by the Federal Ministry, especially around MNCH policies and regulations. So what are some of the steps Ministry has taken at the national level to address the abortion-related stigma and quality of care in service provision? So over to you, Dr. Atia. And you have 5 minutes.
Can you hear me?
Yes, we can.
Yes. Okay. So thank you very much, Dr. Yasmin, for handing over to me. And I really feel honored to be a part of today's event. And let me first of all thank SOGP and IPES Pakistan for giving me this opportunity. As far as Federal Ministry of National Health Services regulations and coordination is concerned, and as you mentioned that I'm working there as a focal point for reproductive, maternal, newborn, and child health, I can just I would like to briefly answer your question regarding the policies and programs about especially sexual and reproductive health and overall RMNCH. Government is a signatory to SDGs, and SDG 3.1 calls for reducing maternal mortality to less than 70 by 2030. And government of Pakistan is striving hard to achieve the targets, but the recent maternal mortality survey has alarmed us that the maternal mortality ratio in Pakistan is still quite high, as it has been documented to be 186. So we still need to accelerate the efforts to reduce the maternal mortality. And among other factors, unsafe abortions is one of the factors which lead to high maternal mortality and maternal morbidity. So, as I already said, that government is focusing on improving the maternal and child health outcomes as the top priority agenda. So, we have now taken up the integration of SRH into national policies, programs, and practices. Regarding the policies, there are a number of documents and policies available at the national and provincial levels. Among them, the National Health Vision 2016-2025, which aims at improving the health outcomes generally and RMNCH specifically, and it also speaks of sexual and reproductive health interventions. Then we have a National Health Vision with 10 priority agenda items for improving the access to RMNCH services. We also have National Action Plan 2018-2023. We have then the 12th five-year action plan, which also speaks of improving the health outcomes and specifically talks of RMNCH services, including SRH services. Then we have Pakistan Economic Survey, and we have obviously the Interministerial Health and Population Forum and the task force as well as the highest policy forum which makes the policies and strategies. So right now, what we are undertaking at the ministry level, we have just completed a current situation analysis of SRH services to identify the needs, gaps, and barriers for delivering integrated SRHR care. Then we have also undertaken service availability and readiness assessment in ICT, and for RMNCA services, including safe abortion and post-abortion care and family planning delivery status. It has been completed in ICT, and recently the report has been disseminated. And now we have planned to conduct similar assessment in 10 more districts across the country, which have been selected for implementation of UHC benefit package. Here I would like to share that ministry is under the process of development of universal health coverage investment case, which is based on DCP3 recommendations of WHO, and universal health coverage benefit package has been developed and endorsed by the interministerial forum for the community and primary health care level. And for the tertiary care level and population level, it will soon be endorsed. So the plan is to start piloting this universal health coverage benefit package across the country in all the provinces and regions and the whole of ICT. And for this purpose, 11 districts have been selected by the provinces and regions. And soon we are going to start the implementation of UHC benefit package, and it includes, among other interventions, it includes the priority interventions for RMNCH, which account for around 60 to 65% of all interventions, and and the package does include uh, sexual and reproductive health services as top priority interventions. So for this purpose, we are also going to develop standardized training packages for community health workers and for the primary healthcare level workers, and then similarly for the doctors working in the secondary and tertiary level hospitals. And we are also focusing on the standardization of quality SRHR trainings across the country in the national institutions. Regarding the laws, we have also started reviewing the current national priority laws, and this is underway to identify the gaps for improving governance and policy environment. Um, the government is also focusing on integration of SRH services at primary healthcare level. As I said before, by piloting a UHC benefit package, and SRH services are at the top priority in among these interventions. And I would like to share a very exciting news that we are also going to pilot a study in ICT for integration of SRHR into the existing health insurance program, Sehat Sahulat program, at OPD level. So far, the services are provided at the indoor level, but now the services for RMNCH, including the services for SRHR, are going to be piloted in ICT first at the OPD level. And then we will be generating evidence for scaling it up in near future. And one thing more I would like to add that we are also reviewing the essential medicine lists to identify the gaps in inclusion of SRH related medicines. So these are some of the initiatives which are recently been
Okay.
taken, and I should not forget to include the initiatives that have been taken by the ministry during COVID for SRHR, for the continuity of SRHR services. We have conducted virtual trainings on SRHR with the support of WHO and COMSETS. And we have also developed an online course of SRH services, which will soon be started. And we are also working on the trainings for infection prevention and control, and the use of PPEs, and even for the telehealth consultations. So these are the initiatives which are being undertaken by the Ministry of National Health Services for integration of SRH services at the policy and program level. Um, Among the programs, you know that
Dr. Tia,
RMNCH
thank you
programs.
so much. Dr. Tia, we are very short of time. I'll be coming back to you. You are the chair of the
Okay,
panel.
okay.
Can you
Thank
please
you. Thank you so
share a
much.
few things at that time?
Okay,
Sorry for interrupting
okay.
you.
Thank you. Thank you so much. Thank you.
So our next speaker is our champion for this work, Dr. Sadia Sinpal. I think she doesn't need any introduction as far as I'm concerned, because everybody knows her. Her championship in this field. She's a lead gynecologist, and she has been holding several board positions in SAFOG and in SOGP, and she has started the Association of Mother and Newborn with Aman, and the rest of her, elaborative CV can be read on the screen. So my question to you, Dr. Sadia, that myths, misconception, and provider bias are some of the major contributed to the stigma that we see around abortion, whether it's a safe abortion or it's post-abortion care. And you have been a master trainer and a champion of VCAT, value clarification and attitude transformation trainings. So, can you share in a few experiences how effective it has been in bringing down the abortion related stigma in the country? Your own assessment. I know there has not been a formative evaluation of this, but your own assessment will be very helpful. Over to you. And Sadia, please stick to
Yeah,
5 minutes if you can. Thank you.
thank you. Yes, thank you, Dr. Yasmin. And we go back a long way, way back to college, Dow Medical College. And as you would recall, nobody taught us the abortion law. And so it's, it's a very worrisome thing that, I'm sorry. It's a very worrisome thing that we graduated from med school not knowing what the status of abortion is, and nobody taught us contraception either properly, the way it should have been taught. So when we do values clarification, I've been doing this over 11 years now with IPAS, and basically dealt with senior faculty of OBS and Gynae from all over Pakistan. They are not aware of the law. They have myths and misconceptions, not just about abortion, but about contraception. And as you saw from Professor Farouk's presentation, the most effective modern contraceptive methods are not being used in Pakistan. And there's lots of misconceptions like, it's mote ho jayenge and stuff like that, and it can cause cancer, heart disease, etc., etc. So similarly, as far as abortion is concerned and religion is concerned, most people don't know about the religion either. And Islam being far more liberal than the Roman Catholic religion about women's issues at least. And there are lots of fatwas from Al-Azhar University and major, authentic bodies of Islam that abortion can be performed for a whole array of indications. So what's happening with these misconceptions is that women who fall into the category of within the legal boundaries, they still end up with unsafe abortions because our providers have very rigid and very unkind attitudes towards women. So as far as the training is concerned, it really works in my own experience. And in fact, I've recently concluded a survey of values clarification activities in Pakistan with the WHO and Ministry of Health, and we will be publishing it soon. And generally, the consensus is that it works. Those few people whom we've managed to address through 1 day or 2 day or 3 days trainings, they do go home with being a more empathetic person. and having and trying to understand what that woman who's asking for an abortion is going through. So there is behavior change, and the problem is there are not enough VCAT trainers in Pakistan. Nobody wants to do this, and including me. I was literally shoved into it by my colleagues to do this kind of training. And but what I have found, because we have translated the material in Pakistani context in Urdu as well, that trickle down trainings at the community level by the organizations own trainers, they have really worked, and they are extremely grateful for the material provided and the help that IPAS has. IPAS has really led the way with Aman. Everyone forgets Aman because Aman was the implementing partner for, yeah, implementing partner for VCAT, while NCMNH was the implementing partner for MVA trainings, which is what I started with doing. And a lot of people don't also know this, that when IPAS came to Pakistan, they came to the NCMNH office and they were being shown the door. No, we cannot work on abortion, please leave. And then we had a rethink. Hang on a minute, we need to address this. And then the rest is history.
Thank you, Sadia. Thank you. That's a very nice way to end. I still remember that time. And our next speaker is another champion for us, who's always been a compassionate advocate for girls and women's reproductive health, Dr. Noreen Zafar. She's the president of Girls and Women's Health Initiative, a non-for-profit venture which believes in wellness with dignity. Great title. She's a reputed master trainer as well as a VCAT. So my question to you, Noreen, we just heard from Dr. Atia about a lot of things that are happening around the policy changes and about the initiative that has been taken. You are a champion and an expert of training the healthcare providers. Do you think it is really making an impact, or women have better access to safe abortion, post-abortion care, and contraception in the country? Over to you, Noreen, and please 5 minutes. Noreen, you're mute.
Thank you very much, Dr. Yasmeen. Pleasure to see you as always. And thanks to SOGP, Dr. Razia Kurejo, Dr. Halima, and all SOGP office holders and IPAS for allowing this opportunity to share this afternoon with all of you people. And as has been said already, the unsafe abortion not only leads to maternal morbidity and mortality, also a lot of disability, and then a cascade of relevant recurrent disruption of family architecture, and then the ripple effect which resonates throughout the country. And like the earlier speakers have said, it is not only the family planning, like Professor Saab said, but also the complete ignorance of the laws, and that dictates us as healthcare providers to behave in a fashion which is most of the times really not even fitting into the human right dimension of healthcare provision. And like Dr. Sadia said, it is not only that the juniors don't know, even, when I came back from England in 1999, had no idea about the abortion law in Pakistan. And unless I started working with all these good people and came out in the public health, I realized how, how we keep working in different isolated institutions and offices, and we therefore are unable to provide the requisite care for the girls and women. So along with reproductive health, which itself is like a taboo subject, quite so much in the previous 2 decades, but now things are better, and the proof is that we are holding a whole session on this. But abortion is particularly stigmatized topic, and I think it also represents the worst kind of discrimination, which is gender based. A loss that only happens with women and girls. So a lot has been done in the last decade, starting from the provincial standards and guidelines in Punjab in 2015, Then SIN followed, then they were adapted at a national level in 2018. Then all of you must be aware of the in-depth stakeholder analysis about the existing PAFP policies, which was concluded in 2018, and then PAF policy followed in Punjab and in Sindh, and I think it will be taken over soon in Punjab too. And then 2020, we had the post-abortion family planning standards and guidelines. And while working on all of this, I think one thing very clearly comes out that once you educate the healthcare providers about the overall situation, about the presence of abortion law, of which many of them are completely unaware, of the rather flexible nature of our abortion law, it also reduces the medical barriers. Using the WHO MEC in all trainings that we have done with IPAS, it really helps to clarify all those myths and misconceptions which we keep thinking women have, but we as healthcare providers have our own basket of that as well. And I think it is very important to not only develop the clinical skills and ensure competency in that, but also to train them, as Dr. Sadia said, in values clarification, and also creating an attitude of compassion and empathy, because that is the only way our resources are going to transform the care that we give to girls and women. And I think another important thing is that we make these standards and guidelines and we keep them on our desks. So until and unless we are able to send it down to the end user and disseminate them and put them into practice and then monitor them, I think we will not be able to accomplish what a common goal is. But having had these documents produced and endorsed by the government definitely gives even senior people like us a lot of confidence in talking about them. Like Professor Farooq Zaman said that, you know, we talk about them in trainings, but when it comes to the real life, we used to tend and shy away. But I think with the hope of practicing it truly in its honest sense, and then you know, trickling it down, I think the services for safe abortion, not only safe abortion services, but also postpartum, post-pregnancy, and post-abortion family planning services will be strengthened, which is really the only way for us to move forward. Thank you.
Noreen. Thank you, Noreen, so much. So the next speaker, and you're absolutely right about all the so the next speaker is going to be Dr. Sara Said Khurram, who's the CEO, co-founder of Sehat Kahani, and CEO of that, which is Women to Women ICT-based solution for high quality access to the healthcare services. And my question to you, Sara, and like I was welcoming you in our fold, is that in the COVID, you have seen an emerging and increasing partnership with SRH World, with Sexual Reproductive Health and Rights World. And when you step in and take that partnership to train the providers who are already, or Sehat Kahani providers, on abortion, post-abortion care and contraception, what kind of feedback you got from it? Did you notice the barriers? Do you think it was challenging? Or do you think it was something that you were able to manage? Over to you, and please 5 minutes.
Thank you. Thank you, Dr. Yasmin Kazi. It is a pleasure to be a part of this panel and be with you all. We're a very young organization, but it is an absolute honor to be here and present our work. So just a little introduction, that Sehat Kahani connects all female doctors to patients needing healthcare using a telemedicine-based solution. We create clinics in low-income communities where nurses help patients connect to online doctors, and we also have a mobile-based application for patients who need healthcare directly, connecting to female doctors 24/7 in less than 60 seconds. We've been working for the last 3 years, and we've done over 250,000 consultations till date. 70% of those has been taken by women, and 25% of those have been for SRH services. But I really want to focus this work for the benefit of the panel on what we've done in the last 5 or 6 months to introduce a healthcare assisted telemedicine model for the benefit of post-abortive care and contraceptive care services in Pakistan. So telehealth has been used extensively in the last 2-3 years, and particularly in COVID-19 for SRH services. In America, there was a Planned Parenthood organization who piloted this in 10 communities in America, and they found that when post-abortive care or when counseling for contraceptives was provided through telehealth services or telemedicine services, it was acceptable by women, it was as comfortable for them as a physical visit, and it also increased compliance to the counseling provided, to medication provided, because the patient had a chance to follow up with the doctor again and again through the phone rather than walking to them and getting a visit planned. So seeing these success stories in the last 2-3 years, when COVID happened, we overall saw a reduced compliance to family planning and post-abortive care because women could not reach their healthcare providers due to lockdowns and generally because of the fear of COVID-19. So Sehat Kahani partnered with iPass, and we're very grateful for this first public-private partnership in which we trained our doctors on the post-abortive care services and counseling on contraceptive services. And we also provided our application to 55 lady health workers, as was shortly mentioned by Shabir Saab as well, so that whenever these workers in their communities need a doctor's help, they can connect the patient through an app to a doctor who's available 24/7. And these doctors were already trained by iPass on similar services. And we saw what we're seeing in that is a huge transition shift, because what you're asking a lady health worker is to use a mobile phone and then connect to a female doctor to help the patient better. And for those 55 providers to do that for 136 times, for women tell us that there is an appetite for such services that can be used extremely cost effectively by lady health workers to connect the patients to doctors if need be. And we saw that the lady health workers connected the patient to doctors primarily for post-abortive care services and for counseling on family medicine and contraceptives. Because सबसे ज़्यादा मसला ये होता है to women who are coming to these lady health workers, all who require general need of family planning services, the lack of counseling. And when that counseling and that education is provided by a female doctor, that adds to the credibility of the lady health worker as well as to the credibility of the information to be provided. And women feel more comfortable in talking to a female doctor through a lady health worker. So we saw that 136 times lady health workers connected to the doctor to provide consultations on post-abortive care services, on counseling, on family medicine. But as we had this success story, and to me, I think this was a remarkable innovation, connecting female health providers, doctors, and patients through technology, there were certain challenges as well. The first challenge is everyone has talked about the law. Unfortunately, in Pakistan, the law on telemedicine is not that clear right now. There is no clear guideline or policy that can tell us how and when telemedicine can be used. Yes, the law says that the necessary treatment can be provided to the doctor, and the COVID-19 SRH guidelines tells us that you can use telemedicine as appropriate, but then we need to define the appropriate. We need to really expand on the appropriate so that whenever a doctor on telemedicine or a nurse uses the telemedicine, they're absolutely aware of what they can do or cannot do. I think the second issue was the initial resistance or the apprehension of doctors who are providing services online, because again, this is a very unexplored, unaware subject that a lot of doctors are not familiar to. So I think the second thing is the training of female doctors as well as the female health workers on how to use on how to use telemedicine as well as the counseling services in their hands.
Sorry, Sarah, but are you done with your talk? Your mic is mute. Okay, you're done. Thank you.
No, I'm saying that I got muted, but I have like 30 seconds more.
Okay, go ahead.
Yeah.
Conclude, please.
And I think the third and the fourth challenge is the sustainability. Because a lot of times that we see that when you try a model like this, it's either funded by the government or funded by the NGOs to provide motivation to lady health workers to try these innovations and make sure they are connecting patients to doctors. So the platform that we are providing provides incentive to the lady health workers to connect the doctor to the patient on telemedicine. And I think these sustainable models are the way to go forward so that everyone makes social economic benefit in the situation. But I just want to conclude with one thing. I think iPass was a very brave organization to pilot this on its own at a public-private level. But until and unless we can get more government level or non-government level organizations introducing telemedicine-based approach, we're only scratching the tip of the iceberg. So I think my urgent request from everyone on the panel is that telemedicine is a very cost-effective, private, and secure way for a woman to connect to a doctor. And if that's assisted by a lady health worker, it augments the response. And I think if you're seeing failure to contraceptive use, that is in one sense because of counseling. And that can be easily and very productively done through telemedicine by lady health workers assisted by doctors. Thank you.
Thank you, Sarah. We have noted that. And I would also think that you should consider training your providers through VCAT, like Sadia and Norina here, because the biases could be dealt with that. It has been proven. So, but a great suggestion by you. Last but not the least is our Arusha Lakhani, who is the president of Midwifery Association of Pakistan. She works in faculty in Aachen University faculty. And she's going to be talking about a question that I'm going to ask her actually. So the question to Arusa is that the study that Pop Council did has shown that 80% of the women who were seeking induced abortion had gone to midwives or a mid-level provider, but unfortunately most of those were untrained. I think most of them were untrained. But with the recent change, which Dr. Atia was also talking about, having MBA and MISO, which is Pakistan Nursing Council, has also approved. Do you think there would be a change in the trajectory of complication that we were hearing in the morning associated with unsafe induced abortion, and how can it improve the high quality safe services for women? Over to you, Rusa, and please 5 minutes. Arusa, you are mute.
Okay, so am I audible now?
Yes, you are.
Okay, so I was saying thank you so much for SOGP and IPAS for inviting Midwifery Association to contribute and participate in such an important agenda. Here I would like to raise a couple of points. One is definitely it will make a difference at the country level, where we are providing education to midwives and nurses on such an important aspect of care. However, it's on the other hand, it's very important to understand that once we take this as a part of curriculum, are the educators, when we say educators, midwifery and nursing educators, are ready and prepared to deliver such content to the students to whom they are providing programs. The second thing that when Dr. Sadia was talking about VCAT, so it's not only knowledge and skills that we talk about in abortion care, it's more of an attitude too. So providing an opportunity of practicing for these nurses and midwives at the ground level, because we have observed over the time that we do deliver sessions in the class, but when we are ready to provide services or learn our skills or knowledge and attitude at the services side, it is very scarce, and we do not get an opportunity to practice or observe or participate in providing care. So because abortion and post-abortion care requires competencies at all the three levels, which I already mentioned. So this is the second thing that we would like to address, that are we ready and are we providing an opportunity for them to practice. The recent thing that Midwifery Association of Pakistan has participated in, we have recently published a book with the McMaster University, Canada, on family planning and post-abortion care, which is for the healthcare professionals, particularly for midwives and LHVs, and which is easily, freely downloadable in a download version at our website, at the Midwifery Association website. And we are encouraging our healthcare professionals and our midwives, our colleagues, to go through that, because it has certain videos which they can observe. It has also interactive activities that midwives or LHVs and nurses can perform and learn about abortion and post-abortion care, which is readily available for them. So a request to IPAS and certainly association can collaborate is to ensure that at the college or the school level, when we address such an important agenda, we really need to understand that we make sure that our educators are ready and prepared to deliver and provide the care which is required by the community at the grassroots level. Thank you.
Thank you, Rusa. That's a great suggestion. And I think APAS is making a note of everything. With that, I would really like to thank everybody, all the panelists, for their valuable feedback and for, of course, two key speakers. And I would now request Dr. Athiya Abru for her concluding remarks for this very, very informative and interesting panel. Dr. Athiya, over to you.
Yes, Dr. Yasmin, am I audible?
Ji, aap bilkul audible and we can see you also.
Okay, thank you. Thank you very much. And as we are already a little late in time management, so I would not take much of the time. I would like to thank, obviously, all the participants, all the speakers and keynote speaker. And I'm really thankful to SOGP for holding such an excellent session on this burning issue. And we at the ministry are very much thankful to all the to all the development partners, the partner organizations which are standing with the ministry for working for the improvement of health outcomes of children, mothers and children. And we are really thankful to IPAS Pakistan. IPAS has been a great partner in taking forward the SRHR initiatives that are undertaken at the ministry level and at the provincial level too. I'm also grateful to the organizers of this conference, and I've been a part of this conference for the third time. I had also attended the SOGP Biennial Conference last year and the year previous to that. But I must say that today's discussion was far ahead of the previous two sessions which we had in the previous 2 years. And we hope and we look forward to undertaking steps to move forward in this area of work, because working for women is actually working for the nation. And we believe in that having healthy mothers means having a healthy nation. So with this, I'm again thankful to all of you, to SOGP, to IPAS, and to all the speakers. And we look forward to continued support by all of you in this area. Thank you so much.
Dr. Razia, Dr. Halima, would you like to just close this session?
Dr. Razia will close because Dr. Halima is not here. Dr. Razia, please unmute your mic.
Yes. Up of SOGP to all of you panelists, speakers, and the chairpersons and all this, and IPAS Association for conducting a beautiful, very informative session on the post-abortion care. So I am thankful to IPAS organization always supporting the SOGP, and I am very thankful to all of you. Thank you so much.
If I may, at the end, I'd like to thank the moderator for conducting the session excellently. Thank you very much, Dr. Kazi.
Dr. Farooq, so nice of you. So nice of you. It's a pleasure. It's a privilege to be with all of you. Thank you so much. Have a great rest of the day. Thank you.
Thank you, everyone.
Thank you.
Thank you very much.